This is Katie Bodine, and we are going to be talking about hypoparathyroidism. Just a brief overview of our parathyroid function. We generally have 4 glands around the thyroid. They're not completely static. We don't all have 4. There might be more or less, but in general, they're somewhere posterior to the thyroid or next to it. And the function is calcium homeostasis. So the parathyroid cells, they manufacture, they store, and they secrete our hormone PTH. So PTH aids in regulating the homeostasis by increasing calcium absorption from the intestine by stimulating the formation of active vitamin D. It also stimulates renal resorption of calcium in the distal convoluted tubule of our kidneys, and simultaneously phosphate excretion. And then it, of course, can actively recruit calcium from bone stores, so it will stimulate that osteoclast activity and mobilize calcium. And this is done when the cells sense a low serum calcium, and so it releases a PTH in order to maintain that calcium level between about 8.5 to 10 milligrams per deciliter, which is pretty amazing. It's a really narrow range there. Picture's worth 1,000 words. This is from osmosis.org. If you need to refresh a little bit deeper into your pathophysiology, they are an awesome resource. So hypoparathyroidism, it's parathyroid hormone deficiency, PTH deficiency, and in general this is an acquired condition. This can be because of damage or intentional removal of the parathyroid gland because you had hyperparathyroidism, or this could be damaged because of a thyroidectomy or radiated thyroid. Oftentimes, this is autoimmune destruction, so it's idiopathic immune disorder, and it just hurts the glands. PGA syndrome is one cause. This can also be done by infiltrative disease, so this is Wilson's disease, hemochromatosis, and thalassemias. We can have functional hypothyroid disease, and this is from low magnesium, because our magnesium is actually needed for the PTH receptor activation on those cells. Another type of infiltrative disease would be metastatic cancer or granulomas. And very rarely we have an inherited or congenital disease. DiGeorge syndrome is one of the classic syndromes where there's an infant that's born with thymic or parathyroid hypoplasia or aplasia. They eventually have T-cell immunodeficiency and hypoparathyroidism. The infants with this will have kind of the classic low set ears, midline facial clefts, small receding mandibles, developmental delay, congenital heart diseases. There's a host of other problems with these poor babies. There's also pseudo hypoparathyroidism, and again, it's inherited disorder of target organ resistance to the PTH. So it's actually not low PTH, but target organ resistance. And these are generally classified according to the manifestations of each type. So regardless of the cause, low levels of PTH lead to low levels of calcium in the blood and high phosphorus, right? So we have several signs and symptoms that will occur because of this. They are different, of course, than our hyperparathyroid. So we may have some obvious signs when a patient walks in because they have a thyroidectomy scar, right? So we're already automatically kind of considering this while we're doing our physical exam. They may have dry, coarse hair, and brittle nails, and some symptoms can be related to low calcium and high phosphate. So one of the hallmarks of this, and I'll say it again, one of the hallmarks of this hypocalcemia is neuroexcitability. Okay, this person might come in having some tingling in the hands and mouth and muscle cramps, and you might be automatically kind of going down the TIA route, but there's some very specific signs that are directly related to low calcium. So one of those is the Chos-Sex sign, and that is when you tap on the facial muscles and they twitch. And usually you want to tap just about 1 centimeter below the zygomatic process. It can also cause a trousseau sign, and that is where you are taking their blood pressure. The blood pressure cuff is enough to annoy the brachial artery, and that's enough pressure on the nerve to make it fire. So then all of a sudden you start seeing the wrist and metacarpal and phalangeal joints flex. It's pretty cool. So in severe hypocalcemia, this can be life-threatening, but they can actually have complications like seizures and cardiac arrhythmias. So all of you that all these years were drawing FOS levels, wondering why is this important? It's important. There's some unique clinical manifestations, like I just discussed, for congenital or inherited forms. We don't need to dive too deep into that. All right, so diagnosis. Because hypocalcemia is a major stimulus for PTH secretion, we should be drawing a serum PTH, a serum calcium, a phosphate, and an ALK phos. Okay, I would consider a CMP just to evaluate liver and renal function, as well as vitamin D, ionized calcium, and a magnesium. So we'll recall that low calcium should stimulate PTH release. So our PTH should be high. So if we have a low or even low normal PTH concentration in the setting of hypocalcemia, this is going to suggest hypoparathyroidism, right? So it's not normal. If we have an undetectable, and I think I have a little typo here, TPH, it should see PTH. This may indicate an inherited form. And then, of course, if we have a high PTH concentration, this is going to suggest pseudo-hypoparathyroidism, or an abnormality of our vitamin D metabolism. Okay, and then hypoparathyroidism can further be characterized with our phosphate draws, and we should have a normal ALK phos because we are not recruiting bone, right? Go ahead and get an EKG. We want to rule out changes that are consistent with any sort of electrolyte derangements that include a prolonged QT or an ST segment or torsades. Remember, magnesium is going to play a role in here. They could have AFib. Okay, so our mainstay of treatment here is going to be our calcium and vitamin D supplementation. Our first line, our preferred method is going to be an elemental calcium carbonate, and we want them to take this with meals so it's better absorbed, and hopefully we can avoid PPIs because PPIs stop absorption of a lot of our medications that it inhibits. Unfortunately, the calcium carbonate is not always tolerated because of constipation, so our second line is going to be calcium citrate. If they have PPI therapy that you cannot get them off, like most of my older patients that have been on it for way too many years, then it's not going. Then your elemental calcium is not going to be absorbed well. So go ahead and use calcium citrate. We're going to use 1 to 3 grams per day. in divided doses if you can get them to do that. I will even take once a day. Our calcitrol is going to start at 0.25 to 2 micrograms a day. And then if they're having a lot of hypercalciuria, consider a thiazide diuretic, because that will help to reabsorb that calcium. And if the phosphate is high, we're going to need to start them on a phosphate binder. In the event of tetany or emergent conditions, super low calcium, they're going to be hospitalized generally in an ICU. They're going to need a central line and a very slow calcium gluconate infusion. They'll remain on a cardiac monitor until their levels are sufficient and their symptoms are resolved. And that's about it. Hope you all have a good day.